So the consensus was for our Monday, Wednesday, Friday class to take the Tuesday lecture and go all the way to the end of the content of the material covered Tuesday and start covering that content with you guys. Everybody still okay with that? All right. It'll help us get done a little bit faster doing it this way. Did you guys want any further information about the placenta and the process of placentation? Placentation, I want you to realize, is a process of placental formation. And that takes the first trimester to complete. So it's about 3 months for that to occur. And it is an extension of implantation. After the placenta has matured, it then will take over the role that actually the corpus luteum had. And so the only reason the corpus luteum is still in existence is because of a certain hormone present, correct? Human chorionic gonadotropin, or HCG. And so the placenta, or the trophoblast, was responsible for the production of HCG and no longer needs to produce HCG because that is no longer necessary because the placenta can take over the job. So HCG levels drop dramatically after the placenta takes over its job because it's doing the hormonal process. And the corpus luteum is responsible for maintaining the uterine lining that first 3 months. And remember, progesterone is exceedingly important for that. And so our corpus luteum is predominantly progesterone, dominant in its hormone production, but it also does produce some estrogen. You guys saw that when you looked at those charts. It actually showed that after the estrogen dropped, progesterone rose, and then some estrogen is actually also being produced. But I want to emphasize its progesterone dominance, which is important for the maintenance of the uterine lining, because without that, we're lost. We realize that the placenta is then going to produce estrogen and progesterone, helps to maintain the uterine lining, helps to maintain the proper growth of maternal organs and processes, as well as growth of the fetus. So even growth of the fetus requires estrogen and progesterone, no matter whether or not it's a male or female fetus. And estrogen and progesterone are produced throughout the pregnancy by the placenta, but as the pregnancy progresses, these levels actually increase. Another hormone produced by the placenta is HCT, human chorionic, just like HCG, human chorionic thyrotropin. And that is a hormone that's going to stimulate the thyroid gland to produce thyroid hormone. What is the hormone equivalent of thyrotropin that we discussed in our endocrine system chapter? What hormone caused the production of thyroid hormone? TSH, thyroid stimulating hormone. So HCT is indeed very similar in its ability to TSH to stimulate activity of the thyroid gland. Let's talk about the extra embryonic membranes that are actually going to form. So we've been successful implantation occurs. It takes 2 weeks approximately for completion of this after ovulation, after fertilization. So within 2 weeks we have successful implantation. And that inner cell mass is going to undergo some morphological changes. And so we have actually an area on one side that's close to the trophoblast that's going to differentiate into the amnion. And then we have an area of cells associated with the inner cell mass that's on the, what I call the more luminal side of that blastocyst that's going to form what's called the yolk sac. So let's talk about that yolk sac. No nutritive value in humans, but it is interesting because it is actually the site of our early blood cell formation, because you remember our marrow is where our blood cells are formed, but yolk sac is where we actually get our first blood cells and blood vessel formation. If you take a look at your pictures associated with the yolk sac, there is this little outpocketing of it, and that's called the allantois. And the allantois is actually going to contribute to the formation of the umbilical cord. And so remember, this yolk sac is what I call forming on the luminal side. Of the inner cell mass or embryoblast. So now on the side adjacent to the trophoblast of that inner cell mass, we end up with an amnion that becomes the amniotic sac, which is going to be full of amniotic fluid that is designed to cushion the developing fetus. So what's interesting about that amnion next to the trophoblast in its formation, you have that inner cell mass that's actually starting to undergo some interesting changes with it. And when we get into week 3, that's called gastrulation. We're going to talk about that next. But one side next to the trophoblast becomes the amnion. The other side next to the lumen of the blastocyst becomes the yolk sac. And the little inner cell mass is going to populate 3 germ cell lines. But the amnion that's on the side next to the trophoblast is going to literally stretch over and envelop that cellular mass that's forming to actually form the amniotic sac. So the entire organism will be surrounded by that amniotic sac, even though it's actually initiating its development only in a certain plane. So that's an interesting aspect to that. The chorion is part of the trophoblast and will end up becoming the fetal part of the placenta, which we actually have already discussed. Let's take a look at embryonic development, because what this means is we've had successful implantation if you're now an embryo. So you are in weeks 3 through 8, and the first thing that's going to happen during week 3 is this thing called gastrulation. And this is going to create the basic framework of the embryo. What's nice about this, gastrulation occurs during week 3, and we end up with 3 germ cell lines forming. So that inner cell mass is going to actually stratify. And there are literally, you can actually see 1, 2, and 3 cellular layers in there. And those are the germ cell lines that I'm referring to. What's important about this, cells from a specific layer will migrate to a specific area to become a specific organ or tissue. And so our embryoblast is now forming an embryo, and the embryo, the first formation of the embryo, will be 3 layers, and we'll be able to identify one as the endoderm, which is adjacent to the yolk sac. Well, I said yolk like the grocery store. At least I catch myself when I do these things. I look at it and go, that's not the way you spell it. And the mesoderm is going to be in the middle, and then the ectoderm is going to be adjacent to the amnion. So that's our first recognition of the embryo, 3 cell lines. And during this time period, weeks 3 through 8, these cell lines are now going to migrate and form various organs or tissues. And let's take a look at this organogenesis process. Let's look first at the endoderm, which was adjacent to the yolk sac. And I want you to appreciate respiratory epithelia, digestive glands, endocrine glands, and urogenital epithelia. This is all epithelia associated with mucosa, yes? So this is mucosal epithelia. And then also glands. When we did our 4 different tissue types way back in the first semester of A&P, one of them was epithelia and glands. And so this endoderm is going to be what's responsible for forming our glands. So digestive glands and endocrine glands. And that's still consistent with epithelia. Now, mesoderm is going to, M for meso, is going to be responsible for the formation of all muscle tissue. So cardiac muscle, smooth muscle, and skeletal muscle all come from that middle layer or mesoderm. And also most of our connective tissue is mesodermal in origin. Serous membranes are also mesodermal, and urogenital organs are mesodermal. The ectoderm, that which is closest to the amniotic sac, is going to be responsible for all nervous tissue. So that came from the ectoderm, and skin, which is interesting. So embryologically, our epithelium of our skin arose in the same area that our nervous tissue arose. And that's what this is actually telling you. So very specific area on this cell line, and all this stuff is going to suddenly move and migrate and form very important structures for us. Melanocytes, to me, melanocytes are also consistent with epithelia of the skin, and so that makes that one easy to memorize. I think ectoderm and endoderm are relatively easy to memorize, and most of mesoderm is also. And that's the only thing that you have to do with that is just basic memorization. So we have made it through gastrulation and organogenesis. And so what that means is by the completion of week 8, we have all of our rudimentary organ systems in place. And so now we are going into week 9, which is our fetal period. And we want to discuss for a moment fetal circulation and the modifications that we actually have to have in order for fetal circulation to occur. Remember that placenta is an interesting life support organ. I view it as indeed as a life support organ. It functions as your lungs, and it functions as your urinary system. It functions as your digestive system. It has multiple functions for you. That's why I liken it to a life support system. It also provides you amnesia from mother's immune system because the mother is carrying a foreign body inside her. So 2 sets of chromosomes, but not mom's chromosomes completely. So that would be foreign material, but the placenta protects the developing fetus from any sort of invasion by any sort of our immune system players. Everything is there with this cardiovascular system, except we have some umbilical blood vessels. And red means what to you? Does red always mean arteries? No. And I said something that should have given you a clue on this one because I said functions as lungs. So think of lungs and what contains red blood from the lung, related to the lungs? The veins. So this is what's important with this picture right off the bat. You have to realize red here is in the venous system. Therefore, blue is arterial system. What is our basic definition that you have to remember so that you don't think about oxygenation, deoxygenation? What is the basic definition of arteries and veins that we've kind of tried to emphasize for you? Take blood away and veins take blood back. So take a look at this. The blood that's going away from the fetus to the placenta, which is a life support organ, should be used blood, correct? In the placenta, it should be processed and freshened up, and then the fresh blood should go back. So if you think of the placenta as a substitute for the lungs, and therefore the circulation going to and from the placenta, that will help you, I believe, in making a little bit more sense of this process. So our placental vein is full of oxygen-rich blood, and our placental arteries, which there happen to be two, or umbilical arteries, excuse me, are full of oxygen-poor, nutrient-poor, waste-rich blood. Let's follow the umbilical vein, I said placental, but umbilical vein back in, and let's see where it goes. It's going into this structure that was blue. If you look at it down here below the liver, what's blue in a normal systemic circulation? That's going to be associated with the abdominal pelvic area. It's the IVC. And so we have here, I'm going to erase some of the stuff. We have here, this structure right here is the inferior vena cava. Well, take a look at that umbilical vein, and it empties ultimately into the inferior vena cava. And what color does the blood turn when that happens in our picture? Purplish, yes? That's a purplish color. So down here, the blood in the IVC is bluish, and that should indicate oxygen-poor blood, correct? This blood is venous blood. It's going back to the heart. Here is the umbilical vein taking oxygen-rich blood that ends up emptying into the IVC. So this oxygen-rich blood is mixing with oxygen-poor blood, creating some oxygenation of this blood, correct? And this blood is going to go from the IVC. Where does our blood go? Into the right atrium. And so this blood goes into the right atrium. This is the freshest blood that the fetus gets. The blood that's coming from the IVC, where the umbilical vein emptied into that. So this blood is going into the right atrium. Well, is that the only blood that goes into the right atrium, the blood from the IVC? No, we have also blood from the superior vena cava. So we further degrade the oxygenation of this blood, correct? What was nicely oxygenated from the placenta, because that's what the placenta did, and it's being sent back to the heart of the fetus. This nice fresh blood is mixing in with blood from the IVC and the SVC in the right atrium. So this purplish blood is even getting to be a darker purple. And remember, from the right atrium, the blood is going to go into the right ventricle, correct? And from the right ventricle, the blood will go into the pulmonary trunk, and from the pulmonary trunk, that will go into the right and left pulmonary arteries, correct? Well, why do we send blood to our lungs in the first place? For oxygenation. So do we need to send all of the blood for oxygenation to our lungs at this time? No, because the lungs are not an oxygen producing or filtering and carbon dioxide clearing organ for us at this time. The lungs are still developing. So the lungs are developing, and so anything that's developing does need blood supply to it, correct? So the blood that goes to the lungs is going to be just to help the lungs develop. Does that need to be a whole bunch of blood? No, just a relatively small amount of blood compared to what we actually ordinarily send to the lungs goes to the lungs for lung development. And so it will go into the pulmonary trunk. We see that right here. And what's interesting is in the pulmonary trunk, when I move this thing out of the way, what do you know in a fetal heart is present between our pulmonary trunk and our aorta? Ligamentum arteriosum in the adult, but ductus arteriosus here in the fetus. And so we are going to basically shunt most of this pulmonary trunk blood into the aorta, because aorta takes fresh blood to our organs, correct? Well, this is the freshest blood that this fetal heart is going to get. So we take this compromised but still fresh, relatively fresh, so that's why I say relatively fresh blood, to the aorta, and then from the aorta, we send it down the thoracic aorta, the abdominal aorta, and all the various branches. You take that blood to their organs. Okay. And so that's why you see in our cartoon picture here, the abdominal aorta is purple, because purple is meant to be a combination of red and blue. So this is oxygenated blood, but not truly oxygenated blood that we are used to. And so this blood, there's another shunt system we're going to talk about in just a moment. This blood that's going to the organs is good enough to help everything grow. And that's one of the things that I want you to understand. The oxygen level of this blood is good enough to help everything grow. It's not going to necessarily make them fully functional, but it's going to help them grow, and function will follow. There is another shunt in this system because the ductus arteriosus is not going to be adequate to actually help move most of the blood to the left side, because the left side is our systemic circuit. And that's what is in the interatrial septum. There is a hole in the interatrial septum, and it's called the foramen ovale. A hole is a foramen. After the fetus is born and is a newborn and stuff, that foramen ovale will ultimately close off and create a fossa ovalis. So that hole is very important, because this blood that we're, sort of fresh blood that we're emptying into our right atrium, is going to be mostly shunted into, and that's why this arrow is here, into the left atrium. The reason this happens is that the pressure in the lungs is actually really high, because the lungs have never been expanded. So they're actually what I call collapsed, crinkled tissue. And so it's hard to force the blood into this tissue. And so the resistance is actually pretty high for our right side of the heart, which means then it's easier to send the blood from anything that you can on the right side into the left side. And that's what the foramen ovale is all about. It helps to send the bulk of the blood that gets into the right atrium to the left atrium. And then from the left atrium, left ventricle, into the aorta, and then the proper circuit. So the fossa ovalis takes care of, or foramen, ovale, takes care of the bulk of the shunt, and then the ligamentum arteriosum is taking care of any additional, what I call inadvertent, not proper divergent of the blood flow to the left side. So those two shunts are very important in making sure this sort of oxygenated blood gets into the systemic circuit. Let's take a look at some of these notes down here. Fetal cardiovascular structures and what we find postnatally. Ductus arteriosus, that's an open thing, becomes the ligamentum arteriosum. Ductus venosus, which we're going to talk about in just a moment, because it's actually going to take the bulk of the blood from the umbilical vein to the inferior vena cava, is going to become what's called a ligamentum venosum, and you did not really look that up much in your work with the cat. Foramen ovale becomes fossa ovalis. The umbilical arteries become what are called medial umbilical ligaments. So this is referring to your belly button. So your umbilical cord is where it used to be at your belly button. And so on the inside of your abdomen, if you take a laparoscope and look on the inside, you'll see these little scarred up kind of little lines on the inside of the peritoneum that actually head off to your internal iliac blood vessels. And so if you take a look here, that's why it's actually showing you right up here the internal iliacs, and that's our medial umbilical ligaments. And that can actually be seen on the inside of your anterior abdominal wall. Your umbilical vein becomes the round ligament of the liver. And the round ligament was in what material? Falciform ligament, absolutely. Excellent. So in our notes, we'll add for umbilical arteries, branches of the internal iliac, sends blood to the placenta. Umbilical arteries, taking blood away from the fetal heart, so to the placenta. If you'll notice, this is plural, and there are 2 umbilical arteries, and this is truly used blood. Our umbilical vein returns blood from the placenta, and this is as fresh, this is honestly as fresh as it gets. Fresh blood, which means oxygenated, it's got nutrients in it, the wastes have been removed, things along that line. What's important to remember is that the umbilical vein will become the round ligament of the liver. With the umbilical vein, we do want to help the liver grow. And so that's why in the notes here it says, some blood to liver. So a small amount of blood will go to the liver, and then also from the liver into the IVC. But most of the blood, the bulk of the blood that the umbilical vein is bringing back will go into our ductus venosus. The ductus venosus empties directly into the IVC, and then we know that blood goes into our right atrium. The foramen ovale is the hole in the interatrial septum and is essentially a major shunt between the 2 atria and will divert right atrial blood into left atrium. Later on, after birth, it becomes the fossa ovalis. And this is the last structure to actually complete the transformation from fetal to newborn or infant circulation. Ductus arteriosus is going to connect the pulmonary trunk to the aorta. Indeed, is identified as a ligamentum arteriosum in the adult. And it is designed to divert, again, this is what shunts do, divert what blood from right ventricle into aorta. Some still goes to the lungs for nourishment of the lungs. So the ductus arteriosus will actually close before the foramen ovale, and that actually makes sense because the foramen ovale is actually a pretty big hole. Let's take a look at some of the fetal features that we will actually be able to identify as fetal development actually progresses. With many studies, there has been developed a method on measuring the size of the developing fetus and to correlate it with various developmental features. And the size of the fetus is referred to as the crown rump length. And so you have what's called fetal position. And so you have that nice curve. And so the crown is, I'm close. The pen is not working so well. The crown is at the outermost aspect of the head, and then the rump area is right back there. And they take a straight linear measurement between those two areas. And that's what the crown rump length is. At 8 weeks, right before we get into our fetal time frame, you have a crown rump length of 30 millimeters. That is just a little bit over an inch at 8 weeks. And all systems are present in the rudimentary form, and so our embryo, with that organogenesis, is saying that everything is here. 4 weeks later, at 12 weeks, your crown rump length is 3 times that. So you're a little over 3 inches in length. So 90 millimeters. And at that time, we have the ability to distinguish what are called crude facial features and can actually detect the sex of the fetus at 12 weeks. What I mean by crude facial features is that we all start off as a flat plate that ends up forming a tube, and then layers actually start to come from our dorsal side laterally to our ventral side. And so everything migrates ventrally, and if that migration is interrupted, there will be abnormalities that will actually be seen after birth or even during gestation when you take a look at the fetus with an ultrasound. But that is the reason for some people to have what's called cleft lip and cleft palate. Something inhibited the forward migration and the midline fusion of those structures. And so you end up with that cleft. At 12 weeks, the reason that the facial features are crude is because your eyes are off to the side, because they have not finished their forward migration. And so that's what we mean by crude facial features. Nose, mouth, but eyes look a little bit like other animals, not necessarily human. At 16 weeks, though, your eyes are in the right spot. They're actually right on the forward aspect of your face. And ears also in normal position because the ears are lagging behind if the eyes are lagging behind. And we can definitely say that the face looks actually human. At 16 weeks, you are 14 centimeters or 140 millimeters, so you're definitely gaining some size at that stage. Then in the next 4 weeks, 17 through 20, at the end of that time frame, your crown rump length is around 190 millimeters. We're still growing pretty much like gangbusters. And our notes state here, fetal position due to space issues. Remember, amniotic fluid is all around the developing fetus. It's designed to cushion it inside the uterus. And what's really important, when before 16 weeks and earlier, you were like, your fetus was like a kid swimming around in a really big bathtub. You know, had all this amniotic fluid, was doing the backstroke, somersaults, flipping side to side, but now has gotten so large that the bathtub no longer is accommodating such type of gymnastics. And so because of that, the fetal ends up kind of in a kind of fixed position because of this size and space related issue. It actually grew into what I call its bathtub. And because of that, now when it moves, it's hitting along the bathtub sides pretty intensely, and mother can feel this. And this is what's called quickening, when the mom first recognizes fetal movement. At this time too, eyebrows and eyelashes are pretty well formed. And the last half of pregnancy, 21 through 38 weeks. The crown rump length at about 38 weeks is 360 millimeters, so we have a pretty good size fetus here, and eyes spontaneously open and close during this time of development from 21 to 38 weeks. Nails complete their formation in the earlier part of this 21 to 38 weeks. But we have some issues with delivery early in this time frame. And most prematures have fairly good survival if their only prematurity is around 27 to 28 weeks. Earlier, more intensive care is needed in order to actually take care of them and help them along the way and with their developmental process. But one of the reasons that they're actually not one, there's two main reasons that they have survival-related issues. And one of them is their lungs. Their lungs are immature. And the immaturity is especially in type 2 cells. And I don't know if you remember about type 2 cells, but those are the cells that produce surfactant. So surfactant, remember, is important in that it does help with lung alveolar expansion, but more importantly, it stops alveolar collapse. So it helps with alveolar expansion, but it's absolutely mandatory to prevent alveolar collapse. So if you don't have enough surfactant, if you blow up the alveoli, they then collapse. And that's a lot of work, always having to blow up your alveoli. And if you're a preemie, you don't have what I call the muscle mass to help you do that. And so preemies very often are on ventilators, correct? So that's one of the reasons for the ventilator use for them is they need that surfactant and they don't have it. And they're on the ventilator as long as it takes them to develop adequate surfactant levels. Once they develop adequate surfactant levels, then you can take them off the ventilator and they can keep their lungs expanded because that's actually what the ventilator is doing. The ventilator is blowing up these little balloons every single time. And that's a lot of work for one little preemie to do all by itself. The other thing that you notice about preemies is where are they located besides the intensive care unit? What kind of environment are they in? They're in an incubator. And the reason they're in an incubator is that they have difficulty with temperature regulation and temperature control. So, hypothalamus issues. Temperature regulation / control. And this is made worse by their overall appearance because there's a big difference when you take a look at a preemie and you take a look at a full-term kid. What is the big difference to your eyes when you look at a preemie and a full-term kid? One is nice and plump. And when I say plump, what do I mean by plump? A lot of adipose under the skin. The adipose is very necessary to actually help us with some of our thermal regulation. It's a little insulator itself. And so temperature regulation is a problem because the hypothalamus is not so mature and also not a lot of sub-Q fat deposition. In other words, it's basically none because you can see those veins in the skin so very easily on those little kids. And so when you are full term, you have adequate surfactant, you have adequate hypothalamic temperature regulation and control, and you have adequate sub-Q fat. That sub-Q fat helps with temperature regulation and control, but it also helps with the first few experiences that the newborn will actually have with life. Because if you're not a product of our American society where we have adequate feeding for newborns, what's the most common method of feeding a newborn? Breast milk. When does breast milk come in? Not day one, right? Yeah, it takes a couple of days for a woman's breast milk to come in. So that means that the fetus, now the newborn, has been cut off from nutrients, correct? There is some colostrum in breast milk, but it's volume-wise, it's not very large. So what do you think that sub-Q fat is for now? It's their storage reservoir for a normal or naturally induced short starvation time frame for them compared to when they were in utero inside. So let's take a look at some of the effects of the pregnancy on the mother. Generally, it is absolutely true. Organs become well vascularized. Lots of vascularity, improve capillaries and arterioles and venules and stuff like that because we have to do more work besides ourselves. The weight gain for an average pregnancy should be around 25 pounds. That's if you're ideal, correct? Just like our 28-day cycle is if you're an ideal female with a 28-day cycle, all of the notes pertain to you. But most people aren't ideal. So 25 pounds is ideal, and there are people who gain less, and there are people who gain more. The ones who gain more will have a little bit more work to do in losing that after delivery of the child because you do not actually need that additional weight to actually take care of the nutritional needs of the fetus. Because all you need to take care of the nutritional needs of your fetus or gestation is 300 calories a day. I think half a PB peanut butter and jelly sandwich will take care of that, yeah? So 300 calories a day. And that's why it's always cute when people say, I'm eating for two. I go, 2 humans? 2 adults? Oh, how many? What's the size? But you don't say that, you just think it, So all they need is, full fat milk. A glass of full fat milk has a lot of calories in it. So it is because people, when they get pregnant, they think they need so much more additional nutrition. That is another reason why we don't see the average normal weight gain of 25 pounds per pregnancy for a lot of people. Changes that are going to occur with the mom that are going to be due to various placental hormones. Remember, placenta takes over hormone production after the first trimester. And various hormones are going to increase throughout the pregnancy, especially estrogen and progesterone. Those guys continue to gradually increase throughout the pregnancy. Estrogen and progesterone are excellent for hair and nail growth. It's enhanced. It actually inhibits the resting phase for nail and hair growth. We can find some hyperpigmentation can occur for a lot of women. The linea alba, the little line on the abdomen, the white line becomes pigmented or darker in coloration, and some women will get what's called chloasma, which is referred to as the mask of pregnancy, where you actually see a lot of pigment deposition in their face and neck and chest area for some women, unfortunately. It does improve after delivery of the child, but may not actually go away and have to use bleaching agents on the skin to get rid of it. Breast tissue growth, estrogen and progesterone are definitely responsible for that. Also, they are responsible for the ligaments of the pelvis getting lax or loose, loosey-goosey. And this is basically due to the high estrogen levels at the end of the pregnancy. So progesterone was important previously. Now estrogen is getting to be very important for the end of the pregnancy. Uterine lining, Again, progesterone, completely necessary for maintenance of the uterine lining throughout the pregnancy. Let's take a look at corticotropin-releasing hormone. That's something related to the adrenal cortex, corticotropin-releasing hormone. This will cause or promote the release of aldosterone during pregnancy. If you are releasing more aldosterone, what does that mean? More sodium reabsorption. So we always pee out a little bit of sodium in our urine, but if we're reabsorbing it, we aren't peeing out as much sodium. And what always follows sodium? Water. So this is responsible for the fluid retention that women get during pregnancy. We'll stop there. We'll take up human placental lactogen next time and on Friday and finish off this chapter and answer any questions you may have about the upcoming exam.